Thank you for the opportunity. So the talk today will be about weaning from mechanical ventilation. This is the outline of the talk. So we're going to talk about introduction first, steps to liberate your patient from the ventilator, and that includes readiness for ventilation discontinuation, spontaneous breathing trial, evaluate if patient passed a spontaneous breathing trial, and then the extubation itself. And then I'm going to talk about some strategies that we can do to quickly and safely get your patient off the ventilator. And those strategies include the fluid status, weaning protocols, choice of sedatives, physical and occupational therapy, and non-invasive ventilation as an adjunct to early liberation. Finally, I'm going to talk a little bit about tracheostomy. So, fundamentally, there are two reasons why your patient is not going to be withdrawn from the ventilator. And that is that the patient is too sick, or the clinician is not attempting to get the patient off the ventilator. Oftentimes, the clinician is not attempting to get the patient off the ventilator. So as soon as the patient is placed on invasive mechanical ventilation, you should start paying attention to the withdrawal process. When I'm going to get this patient off the ventilator. Failure to recognize ventilator withdrawal process leads to longer stay, higher cost, excessive sedation, longer exposure to high airway pressure, volumes, and increased infection risk. And clinicians are not really good predictors to tell whether a patient is ready to be extubated or not. So you really have to do that in a systematic way. On the other hand, overly aggressive withdrawal attempt is also dangerous. You can lead to hypoxemia, aspiration, increased work of breathing. Failed extubation is associated with 8 times higher odds of infection and 6 to 12 times increased risk of death. It's hard to say whether the failed extubation itself led to increased risk of infection or death, or the patient was sick to begin with. So those are all observational studies. But failing an extubation is obviously not a good thing. So you got to find a balance. So you got to ask yourself, what is the reintubation rate? And I can tell you that most studies, the reintubation rate is between 5 and 20%. So having a reintubation rate of around 10% seems adequate. If it is lower than that, maybe you're not attempting enough to get your patients off the ventilator. If it is more than 20%, then maybe you're being too aggressive. This rate may be a little bit high in patients with neurological diseases. So then what are the steps that you're going to take to liberate the patient? It starts off with evaluating readiness for ventilation discontinuation. And that has 4 steps. So you got to ask yourself whether the indication for ventilator support has been reversed or at least controlled. You got to ask about if there is adequate gas exchange. You got to make sure the patient has ability to initiate a breath. And you got to make sure the patient is hemodynamically stable. So that goes into readiness for ventilation discontinuation. Then you go into a spontaneous breathing trial. Then you evaluate if the patient passed the spontaneous breathing trial, and you go ahead and extubate if that's the case. So we're going to start off with readiness for ventilation discontinuation. What that entails. So that has 4 steps. Reversal of indication for ventilator support, adequate gas exchange, ability to initiate a breath, and hemodynamic stability. So here, reversal of indication for ventilator support, basically the underlying disease needs to be controlled. If the patient has an MI, you want to make sure the cardiac enzymes are not going up. If the patient was intubated for pancreatitis, you need to make sure that pancreatitis is getting better. You also want to avoid extubating someone who has high fever. It's okay if the fever, low-grade fever, but high fever, you want to perhaps avoid that. You want to avoid extubating someone who has major electrolyte imbalances. And you want to avoid extubating someone whose liver function is getting worse day by day. And another step is adequate gas exchange. So readiness for ventilation discontinuation, you got to look at the gas exchange. You want to make sure the PO2 is above 60. You want to make sure the FiO2 is equal less than 0.5. You want to make sure the PEEP is equal less than 8. We don't use that too much, but ideally the dead space to tidal volume, VDVT, should be less than 60%. And you want to make sure the minute ventilation is less than 12 liters per minute. So that goes into adequate gas exchange. Finally, you want to make sure the patient can initiate a breath. And I can tell you that the main reason why patients do not initiate a breath is that they are being sedated. So you want to do what we call a spontaneous awakening trial, okay? So that means you're going to stop sedatives and analgesics to the extent that is possible. Sometimes you have to keep some analgesics for 4 hours, for at least 4 hours. And then you're going to look whether the patient passed a spontaneous awakening trial. So patient should not have active seizure or alcohol withdrawal. To do that, you want to make sure the patient has no active seizure or alcohol withdrawal, no ongoing agitation, no myocardial ischemia, no increase in intracranial pressure. But then you're going to look at whether the patient passed a spontaneous awakening trial. So basically you want to evaluate whether the patient opens eyes to verbal stimuli. And sometimes the patient doesn't pass this. It's very common for the patient to get anxious or agitated. The respiratory rate goes above 35. The oxygen saturation goes down to below 88. They develop arrhythmia or respiratory distress. If something like that happens, then you have a failed spontaneous awakening trial. What you're going to do is you're going to resume the sedation, but ideally half the dose that you had before. Okay, so you're not going to keep going into a weaning if you notice that the patient failed a spontaneous awakening trial. Then, within readiness for ventilation discontinuation is hemodynamic stability. You just want to make sure that your patient is stable. You're not going to extubate someone who is in a high dose of pressure or whose pressure requirement is going up. So you also don't want to extubate someone who has unstable arrhythmia or who is having active MI. So then you do within the readiness for ventilation discontinuation, before you move into a spontaneous breathing trial, you want to look at these parameters here. Mouth occlusion pressure, we don't do that very often, but it is in the literature. There has to be less than 6 centimeters of water. Vital capacity, that we do here, has to be more than 10 cc's per kilo. Maximum respiratory pressure, we do that, has to be more negative than minus 30. You want to look at your minute ventilation, and that has to be less than 10. Maximum voluntary ventilation, we don't do very often here. Rapid shallow breath index, we do that. It has to be less than 105, and your respiratory rate less than 30. So you look at these parameters, and if the patient is doing okay within these parameters, you move on to a spontaneous breathing trial. So, and this spontaneous breathing trial can be done in a number of different ways. You can do it with a T-piece connected to the endotracheal tube, or it can be via ventilator. And via ventilator, there are also different ways you can do that. You can just leave a low level of pressure support and PEEP of 0. You can leave a PEEP of 5 and no pressure support. You can do a pressure support between 5 and 10 and PEEP of 5, and this is what we do most of the times here. Or you can just do tube compensation. You can leave the patient on the ventilator and just provide the support to overcome the resistance of the endotracheal tube. And the timing, how long this spontaneous breathing trial is going to last, traditionally it started off with 2 hours. We do 1 hour here. There's evidence that just 30 minutes of spontaneous breathing trial is enough. So I like that. You don't want to keep the patient for too long on a spontaneous breathing trial. So, a little bit of physiology. Why do some clinicians use press support or tube compensation? The idea is to overcome the resistance of the endotracheal tube. And so does that matter? It matters in patients who have a small tube size or nasally intubated. But you should also realize that the use of PEEP and pressure support may give a false impression that the patient can be safely extubated. And that has to do with the effect of pressure support on airway resistance and work of breathing. It has also to do with the hemodynamic effects of pressure support and PEEP. So let's look at the effect of pressure support on airway resistance and work of breathing. After extubation, there's inflammation, edema of the upper airways. So the work of breathing against the supraglottic airway after extubation is similar to that against an endotracheal tube. So any level of pressure support may underestimate the resistance the patient is going to encounter once he's extubated. For instance, a pressure support of 5 decreases the inspiratory work by 31 to 38%. A pressure support of 10 decreases the inspiratory work by 46 to 60%. And what about the hemodynamic effects of pressure support and PEEP? So we're going to look at the preload, so atrial filling, and the afterload, so impedance to ventricular emptying. So systemic venous return, so the preload is equal to the pressure in the extrathoracic veins minus the right atrial pressure. So mechanical ventilation decreases this gradient. So the positive pleural pressure is transmitted to the right atrium. So there's a decrease in the venous return. Therefore, mechanical ventilation decreases right ventricle preload. What about the effect of mechanical ventilation on the left heart? So afterload is equal to transmural pressure of the aorta, which is equal to intravascular systolic pressure minus pleural pressure. Again, mechanical ventilation increases the pleural pressure, so the transmural pressure will decrease during mechanical ventilation, so the left ventricle afterload will decrease during mechanical ventilation. So, in summary, what happens when patients undergo positive pressure ventilation with withdrawal? When you take them from the mechanical ventilation. So there's a rapid right ventricle dilation due to increased venous return. There's reduced left ventricular compliance. There is increasing left ventricular afterload, increasing pulmonary artery occlusion pressure, and there's also edema of the upper airways. So then what is the practical implication of all of this physiology? The practical implication is that you're going to be really careful when you're dealing with patients who have low cardiac or respiratory reserve, when you're dealing with patients who have systolic heart failure, bad COPD. In these patients, it might be a good idea to do a 30 minutes of TP trial or flow by. So you leave the patient connected to the ventilator, but use pressure support of 0 and CPAP of 0. Even though there are not many studies in the literature supporting that. But anecdotally, we do see some patients who just crash after they get extubated. So then you did your spontaneous breathing trial for 30 minutes or 1 hour, and then you're going to evaluate if the patient passed this spontaneous breathing trial. And that's very simple. You just look at the simple parameters here. You just look at the respiratory rate. You want to make sure that it's less than 30, 35. You look at the accessory muscles. You want to make sure the patient doesn't have an increased work of breathing. You look at dyspnea. You look at thoraco-abdominal paradox. You look at your pulse ox. You look at your heart rate. And it's clear that some patients you put on spontaneous breathing trial, the heart rate shooting up. That means that the patient is failing. Okay. You look at the blood pressure. That is also a good sign. Some patients you put on a spontaneous breathing trial, the blood pressure is going to shoot up. That's another sign that they are failing. You look at the anxiety and you look at diaphoresis. And if the patient is doing good within all these parameters, it means the patient passed the spontaneous breathing trial. But before you move on and extubate, you want to make sure the patient is doing neurologically well and the patient doesn't have a lot of cough. Okay? So, in terms of neurological examination, all you need to do is just evaluate 4 simple tasks. Can you open your eyes? Can you follow me with your eyes? Can you grasp my hand? Can you stick out your tongue? Okay? Then, we don't do it here very much, but you want to make sure the patient has a good cough effort. So in some studies, they use the cough peak flow more than 60 liters per minute. Again, we haven't been using that, but you want to make sure the patient has a good cough effort. So you can do that bedside. And again, in some studies, they have actually measured the amount of secretions. We haven't been doing that, but you want to make sure and talk to your respiratory therapist and your nurse and make sure the patient doesn't have a lot of secretions. And this is just showing the predictive value of these variables. So if you don't have a good cough, the likelihood that you're going to fail is 2.2. If you have a lot of secretions, 1.9. If you cannot do one of those 4 tasks, evaluating the neurological status, the likelihood that you're going to fail, likelihood ratio is 4.5. And then finally, if the patient passed the spontaneous breathing trial, you're going to go ahead and extubate. Okay? So the cuff leak test is a little bit controversial. Some centers do routinely, others do it on patients who they feel are at risk of laryngeal edema or post-extubation stridor. So what is the cuff leak test? It's a test to predict development of upper airway obstruction after extubation. So it measures the difference between the insufflated volume and the expired volume access control model after balloon deflation. So you deflate the balloon, you just see how much is going in, so your tidal volume, see how much is coming out. And a low cuff leak volume, so 110 or 130, suggests a high risk of upper airway obstruction. So you want to make sure there's a lot of leak, right, when you deflate the balloon. If there is not leak, then there's a higher chance of patient developing edema. But the presence of a leak does not completely rule out upper airway edema anyway. There was one clinical trial, was published in 2007, that looked at patients on mechanical ventilation for more than 36 hours who had planned extubation. You're about to extubate. And they gave placebo, VES-IV, solomedrol, 20 milligrams every 4 hours, started 12 hours before extubation. They randomized 761 patients. And the primary endpoint was laryngeal edema within 24 hours after extubation. And they found for the patients who got steroids a low rate of laryngeal edema, so 3% versus 22%. So in patients who don't have a cuff leak, it is a good idea to give a little steroid before you go ahead and extubate them. So I just want to get you familiarized with these terms here that are coming up in the literature more and more. So what is a simple weaning? Simple weaning means a successful extubation first attempt. Difficult weaning means a failed initial weaning and require up to 3 spontaneous breathing trials or as long as 7 days from the first spontaneous breathing trial to achieve successful weaning. And prolonged weaning is patients who fail at least 3 weaning attempts or who require more than 7 days of weaning after the first spontaneous breathing trial. For simple weaning includes about 70% of the patients in the ICU. The ICU mortality is 5% and the in-hospital mortality is 12%. On the other hand, difficult and prolonged weaning includes 31% of the patients, and the ICU mortality is 25%. So that matters. Okay, so now I'm going to go to the second part of my talk, which is strategies to quickly and safely liberate the patient from the ventilator. And these strategies include fluid status, weaning protocols, choice of sedatives, physical and occupational therapy, and non-invasive ventilation as an adjunct to early liberation. So we're going to start off fluid status. So recently, in 2012, there was a randomized controlled multi-center trial that included 304 patients during weaning. They designed a strategy based on the brain natriuretic peptide, and they would give diuretics based on the BNP level. So if the BNP level was more than 200, fluid intake was restricted and furosemide giving 10 to 30 milligrams every 3 hours to achieve a target urine output of 4.5 to 9 mL per kilo over 3 hours. And the primary endpoint was time from randomization to successful extubation. So this is just to show that patients who were in the experimental group, they got treated more times with furosemide. So patients treated at least once with furosemide during weaning. The percentage here was 81% versus 71% in the control group. And they found a decreased time to first extubation in patients who got diuretics based on the brain natriuretic peptide, and the median was 39.8 versus 47.7. This was statistically significant. So they're able to get the patients off the ventilator by keeping the fluid status more in the dry side. And this also is consistent with another clinical trial in ARDS patients, where in the experimental group received diuretics based on the CVP. And so the experimental group ended up receiving much more diuretics as compared to the control group. And in that trial, they also found better outcomes in patients who got more diuretics. So another strategy to get your patient off the ventilator quickly and safely is weaning protocol. Like I said, we are not very good predictors to tell whether a patient is ready to be extubated or not, just based on clinical judgments. So it's better to use a protocol and do that in a systematic way. So what is a weaning protocol? It's a structured guide for reducing or discontinuing mechanical ventilatory support. So you got objective clinical criteria to decide if patient is ready to breathe without ventilator. So that's readiness to wean. We talked about that. Structured guidelines for reducing ventilatory support. That's called spontaneous breathing trial. We talked about that. And then criteria for deciding if patient is ready for extubation. We talked about that. We have that here at University of Louisville Hospital. We have a protocol you can actually print when you go to the MICU. So this is just a meta-analysis that pulled several studies that compare the use of a protocol versus no-protocol and showed better outcomes. So this is total duration of mechanical ventilation. This is favorable protocol, so better outcomes. So clear evidence that using a protocol to get your patient off the ventilator for the weaning process is a good thing. So mechanical ventilation, the protocolized weaning group was on average reduced by 26%, and weaning duration was reduced by 70%. What other strategy we have to get your patient off the ventilator quickly and safely? Choice of sedatives. So this is a randomized, double-blind clinical trial. It was published in 2012 in JAMA. And it was also multi-center, and they compared midazolam versus Precedex. And the trial had about 550 patients, a little bit more than that. And the endpoints were proportion of time at target sedation level and duration of mechanical ventilation. So there was no significant change in time at target sedation, comparison between midazolam versus Precedex. However, duration of mechanical ventilation was shorter with Precedex. So 123 hours versus 164 hours. And that was significant. On the other hand, if you compare Precedex with Propofol, they are similar. Similar time at target sedation, duration of mechanical ventilation. What does that tell us? It tells us that if you can avoid benzodiazepines, that is great. Benzodiazepines do lead to prolonged mechanical ventilation, higher rate of delirium as well. What are the strategies you can use to get your patient off the ventilator? Physical therapy, occupational therapy. So, as you know, mechanically ventilated patients are at risk of ICU-acquired weakness. Clinically significant weakness occurs in 25 to 60% of patients on ventilator for at least 5 days. That leads to prolonged mechanical ventilation duration and ICU in a hospital stay. And this ICU, we call that ICU-acquired weakness, has two basic pathophysiologic processes leading to that. One is critical illness myopathy, which is more common, and there's a higher rate of recovery. Another one is critical illness polyneuropathy, which is has to do with primary axonal degeneration. That's less common and it takes longer to recover. Oftentimes patients will have both, and to actually find out what it is, you'd need electroneuromyography, sometimes you need muscle biopsy. So for that reason, we like to just call ICU-acquired weakness, because oftentimes we're not going to do electroneuromyography. There's no evidence that by doing that we're going to be helping the patient anyway. So both conditions are manifested by limb and respiratory muscle weakness and retain sensory function. So here you have primary axonal degeneration. This is a nice review article in the New England that was published in 2014 that talks about ICU-acquired weakness. So then what can you do to avoid ICU-acquired weakness? Well, hyperglycemia in some studies have been associated with ICU-acquired weakness, and there's some observational evidence that perhaps by keeping the blood sugar better controlled, you might be able to avoid ICU-acquired weakness, but you don't want to do tight control because that has not been shown to be associated with good outcomes. Actually, it was associated with worse outcomes. But you don't want your patient to have a blood sugar persistently above 200 in the ICU. Okay? Optimize nutrition, it makes sense. Correct electrolytes, of course, you want to make sure your phosphate is okay, your potassium is okay. Avoiding steroids and neuromuscular block, and particularly the combination of both, seems to be associated with ICU-acquired weakness, although in a recent trial where they used neuromuscular blocker, cisatracurin, for patients with ARDS, no ICU-acquired weakness was noted, but a number of other observational studies have shown that these drugs are associated with ICU-acquired weakness, and particularly the combination of both. And early mobilization, that's important. So you want to mobilize your patient early. And this is the focus here. So this was a randomized clinical trial. It was done here in the US and published in 2009 in Lancet. So they included sedated adults in the ICU on mechanical ventilation for less than 72 hours. And they randomized these patients to early exercise and mobilization versus standard therapy. And the primary endpoint was number of patients returning to independent functional status at hospital discharge. Secondary endpoint was ventilator-free days. And there are a couple of exclusion criteria. I think in this particular trial it's important that you look at your exclusion criteria. So baseline functional dependence was an exclusion criteria. Rapidly developing neuromuscular disease was another exclusion criteria. Cardiopulmonary arrest, irreversible disorders, and raised intracranial pressure. So what they did for unresponsive patients, they did passive range of motion exercises for all limbs, 10 repetitions in all cardinal directions, and therapy coordinated with daily interruption of sedation. For interactive, so those are patients unresponsive on the ventilator getting this. And for interactive patients, again, on the ventilator, they did active assisted range of motion exercises, active independent range of motion and mobility activities. And mobility activities went from putting the patient sitting on the bed, sitting on a chair, up until walking with the patient on the ventilator. So again, I think it's important to notice what they used to exclude the patients. So therapy was not started. Even if the patient was enrolled in the study, therapy was not started if the mean arterial pressure was less than 65, or more than 110, if the systolic blood pressure was more than 200, if they had bradycardia or heart rate above 130, if the respiratory rate was less than 5 or more than 40, if the pulse ox was less than 88, again if they had increased intracranial pressure, active GI bleed, active MI, continuing procedures, hemodialysis, and agitation. So, yeah, I mean, there are a couple of exclusion criteria you've got to pay attention to. But they found higher return to independent functional status at hospital discharge. At hospital discharge, 59 versus 35%. Shorter duration of the delirium, 2 days versus 4 days, and more ventilation-free days. So this is remarkable to me, and something that unfortunately we don't see patients getting too often. So another strategy would be non-invasive ventilation as an adjunct to early liberation. So in 1998, there was a classic paper. It was a multi-center clinical trial, 3 ICUs, intubated patients with COPD and acute hypercapnic respiratory failure. TP's weaning trial was attempted 48 hours after intubation. If TP's failed, they would either extubate and apply non-invasive ventilation by face mask, or they would continue the mechanical ventilation, extubate when they felt the patient was ready. And they found that at 60 days, more patients who received non-invasive ventilation was weaned. The mean duration of invasive ventilation was low in patients who received non-invasive ventilation, and the survival at 60 days was higher in patients who received non-invasive ventilation. So there's also a meta-analysis that pulled 9 studies that looked at non-invasive ventilation as an adjunct to early liberation, and they found lower mortality rates, but they also found most patients had COPD. Some of the studies had a high risk of bias, so they gave a recommendation grade 2B. Also, I think it's important to realize that when you're going to use that strategy, it means extubating the patient, putting the patient on invasive ventilation right away. You don't wait until the patient starts getting tired after you extubate to initiate non-invasive ventilation, because I see that as a common mistake. So we're going to use that strategy, but instead of extubating, putting the patient on invasive ventilation right away, we just let the patient be, and then when the patient starts getting tired, we put the patient on invasive ventilation. That's not how the studies did, okay? So if you're going to use that strategy, you're going to put the patient on invasive ventilation right after you extubate the patient. So finishing up with tracheostomy. So what are the benefits of tracheostomy? Enhanced comfort, improved pulmonary toilet, decreased sedation requirements. But tracheostomy also has some risks. We can divide those into early risks, which include stomach bleeding, esophageal airway injury and barotrauma, and late risks, which include infection, tracheal malation, tracheonominate artery fistula. A recent meta-analysis pulled 16 trials and comparing early within 8 days versus late on no tracheostomy. They found no difference in ICU mortality or 1-year mortality. I like to monitor the respiratory function and see if the patient can come off the ventilator without a tracheostomy. So I tend to postpone a little bit more. There is, again, no data for or against early tracheostomy. You find different physicians have different practices. If the reason why the patient is on the ventilator is respiratory failure, I like to see if the patient can improve on that, and I can get the patient off the ventilator without doing a tracheostomy. On the other hand, if the reason why the patient is on the ventilator is for neurological disease, then I agree that early tracheostomy is a good idea. So just to conclude here what we talked, to liberate a patient from the ventilator, you apply 4 steps in a systematic way. So you evaluate for readiness for ventilation discontinuation. Whatever brought the patient to the ventilator, has that been controlled? So reversal of underlying disease. Does the patient have adequate gas exchange? I'm not going to do that if the patient has a PEEP of 12, if the FiO2 is 70, if the patient blood gas today, the PO2 was 50. Can the patient initiate a breath? So have I done a spontaneous awakening trial? And if so, has the patient got awake? Is the patient hemodynamically stable? Is the pressure requirement going up? Is the patient have an active MI? Is the patient have unstable arrhythmias? So this is evaluation for readiness for ventilation discontinuation. Then you look at some parameters we talked early on, and then you do a spontaneous breathing trial. And the spontaneous breathing trial can be 30 minutes or 1 hour, can be in different ways, can be TPs. We don't do TPs as often here. Can be press support plus PEEP, can be just press support, can be just PEEP, can be just tube compensation. We talked that perhaps in patients who have heart failure or bad COPD, you might want to do either TPs or just the flow by from the ventilator for 30 minutes. But you're going to do the spontaneous breathing trial, and after the spontaneous breathing trial, you're going to be looking at simple parameters to see if the patient passed, and then you're going to extubate the patient if the patient passed. Then we talked about the strategies to get your patient quicker off the ventilator, and those include keeping the patient more on the dry side if they are hemodynamically stable, using a weaning protocol, and we do have a weaning protocol here in the ICU. Choice of sedatives, so avoiding benzodiazepines might be a good idea. Physical therapy and occupational therapy, this is a challenge. We don't see patients having that too much when they are ventilated, but there is evidence that this is a good thing. And plus minus here, I think you gotta have some experience, but using non-invasive ventilation as an adjunct to early liberation in some particular patients might be good. All right, great, thank you.